Since the heart is the location of the highest number of fatal pathological circumstances, it's way important that we be up on top of the structure and the threats to the structure of the heart. So we begin with coronary artery disease. It's through these arteries that oxygenated blood and nutrition come to the tissues of the heart muscle. Through these arteries, if there is change in the composition of the artery, if they become sclerosed, which means hardened, or they become, the intima becomes narrowed, there's stenosis, then oxygenated blood won't get to the tissues and there's a threat of cell death. And we're going to talk about myocardial infarctions and differentiate between those, that pathologic threat and also angina. We'll come to those. The sclerotic changes, or the hardening of these arteries, really happens through thickening of the walls of the artery. That is atherosclerosis, when the walls actually get thick. You can see here, these are real clean walls. The diameter of this artery and the condition of the walls is real great. Contrast that with buildup of deposits between the walls, which narrows the lumen, which means blood pressure would go up and not as much oxygenated blood is going to be delivered. I think it's quite clever. Not sure who said it, but it's not the donut that's diseased. I blew it. It is the donut that's diseased, not the hole. So the greatest threat to arterial health and then indirectly the health of the heart muscle is buildup of plaque inside of the wall. Now, obviously, arterial sclerosis includes plaque that builds up in the intima. That can lead to thrombosis. So the progression of coronary artery disease is from ischemia, which is a symptom of not enough oxygen. If you think about maybe tying a finger with a string, wrapping string around your finger, and it began to scream at you, it's hypoxic. Well, if heart muscle doesn't get enough oxygen, then it's going to scream. If it really screams loud, it could be a result of completely cutting off the circulation. But the progression is through atherosclerosis, which is a buildup, thickening of the actual wall. Muckenberg's arterial sclerosis, I'll show you a picture of that. Arteriolar sclerosis, the smaller branching off of the smaller diameter delivery system of the arterioles, and then manifestation. If all of these are in place, the person's going to complain about chest pain. It'll be submaximal. They might report, you know, a 2 out of 10 or a 6 out of 10, but they're not going to report a 10 out of 10, which is really associated with an MI, myocardial infarction. And then the possibility of a thrombus forming. It goes on the move. It can become an embolus and go into smaller tubing and cause cell death. Progressive angina, and then, like I've indicated, myocardial infarction. Atherosclerosis is a type of arterial sclerosis, and I'm showing you that the lumen, the wall, the opening is way clean. The wall begins to thicken and it gets way thick. And so you've heard of people who have just a percentage of blood passing through there, or it's 90% blocked, right? Well, blood pressure is going to go up, and the delivery of what the heart needs is going to be deprived. Here's an example of where the aperture here is just narrowed so dramatically that this person is destined for, if it's not corrected, then it may cut off blood supply to the heart. Atherosclerosis, you've got some expression of how the aperture is affected. If plaque is laid down in the vessel wall, then it can be kicked out. It's roughened, and it also becomes very sticky and collects more bloodborne debris. Actually becomes a chronic inflammation. The inflammatory cycle's in place, and that causes more hypertrophy. Muckenberg's arterial sclerosis, the calcific plaques form in the arterial walls. I really think this communicates how the wall gets big, yeah, because of this laying down of plaque. Well, then this narrowing, things are running into this. Thrombocytes, this becomes irritated because of the current flowing across it, and it becomes roughened, inflamed, and it just builds up debris on the outside, which causes this aperture to be narrowed even more. And this is captured in the PowerPoint on this slide by what's happening in these constrictions, microvascular lesions, as a result of sclerotic changes. I want to talk to you about an early warning sign. This is after atherosclerosis, arterial sclerosis, arteriolar sclerosis, and then pain production as a result of not getting enough oxygenated blood to the heart. There are different types of angina pectoris. When a person can count on, when they get up in the morning, they're going to have a few minutes of chest pain that's lower down on the scale, mild to moderate discomfort in their chest, and the doctor may have prescribed nitroglycerin for under the tongue. Very often that solves it in the early stages, and then they don't have it anymore. That's called chronic. They can expect to have that happen. Anyone who has that happen, it's a new onset, they need to go in and have a baseline done on heart function. If it happens at night, it's a little bit more serious because that's when the client is quiescent. It's possible to develop this after a myocardial infarction, which I'll talk about again. It could be a warning sign of complete blockage and therefore a heart attack called a myocardial infarction. If it happens at resting, like in sleep, this is problematic because it's a harbinger for something that's coming. And then labile is that it's unpredictable or idiopathic, not sure why it happens, but it's happening. If the plaque inside the lumen becomes dislodged, it's a thrombus, and it's going to move, in this particular case, if it breaks loose here, it's going to go down into the more narrow channel of the artery, and it can completely block that off. So that has to be removed. This is a piece of equipment, go through the femoral artery in the anterior leg. They bring it all the way through the chambers of the heart and get it down into position to remove the thrombus before it kicks loose and goes to the lungs or kicks loose and goes to the brain. Progressive ischemia. Ischemia is defined as a decrease in oxygenated blood, and it's not a complete cutting off, it's a decrease of blood. So if you'll look here, there's a stenosis in this artery. Right here is a blown up version of that. There's still some oxygenated blood getting through, but this would cause angina pectoris. If the thrombus goes on the move, it's labeled as an embolus. And you've heard about people who had an embolus in their calf from inactivity, post-surgical, or a person who's on a very long plane flight, or military personnel who are cooped up in a tank or a personnel carrier and they're not getting enough circulation. Well, these form and then go on the move, and it can be fatal. The myocardial infarction is depicted nicely here, where the stenosis occurs here. Here's the embolus. It completely blocks this off, and necrosis results. Can you live without this portion of the heart? Maybe, maybe not. If enough of the heart dies, not going to function, not going to be in rhythm, can be threatening. To go to a level of sophistication beyond that, appreciate the fact that there are 3 zones. The outer zone is the zone of ischemia. Some people say ischemia, I say ischemia, this outer zone. So this is the zone of the heart that should be supplied by this artery, but there's a thrombus. And so this outer zone is benefiting from collateral circulation from other arteries. But the deeper tissues, the next zone is called the zone of hypoxia. It's more likely to stay traumatized after this is corrected. The zone of infarction and necrosis will never come back. Once it's deprived of oxygen for a period of time, it's dead. It won't come back. I'd like you to be a student of modifiable behaviors, non-modifiable, and contributing factors for coronary artery disease. We'll work on that in class today. Well, if there's coronary artery disease, there's a number of fix-it kinds of things. One is a stent through an angioplasty, where this stent is put in, pumped up, and it pushes that plaque up and out. There's a lattice work here that won't fail. If all they did was to pump it up, then it's been shown, the evidence shows that fails. But if you leave the stent in, it keeps the lumen open. Another treatment for coronary artery disease is the bypass surgery. So in this particular case, the blockage right here at the artery, there's a harvesting of the saphenous vein from the anterior foot and the medial crurus. That's put in upside down so the valves will be favorable. This goes by the blocked artery so oxygenated blood can pass. That's a compensation for this artery being clogged. I think we'll stop there and be a student of the heart. Remember to bring your stethoscope to class. We'll be auscultating the heart and doing blood pressures, and you need your stethoscope for that. So bless you guys. Bye.